Good afternoon. On this Sunday afternoon, I want to welcome you to the Network of Medical Audiology Professionals presentation on COVID-19 and audiology. This is going to be just a brief overview of current medical research. Things are developing daily as it relates to COVID-19 in other medical arenas as well as within audiology. So just know that there are many things that have occurred. I've only highlighted a few of these areas and have a list of resources for you to be able to continue this ongoing research that we're going to need as it relates to COVID-19 and what we may see as long-term symptoms. So my name is Dr. Patricia Ramos. I'm the Director of Audiology and Rehabilitative Services at ENT and Allergy of Florida. I have been in the area of audiology in Florida for my entire career, native North Carolinian that moved to Florida and just never went back. North Carolina is a beautiful place, but the Florida sunshine just got all into my system. Impossible to go back. So I have spent my entire career in the medical audiology arena, collaborating with ENTs as well as other providers on collaborative patient care. I do not have any thing to disclose during this. I don't have any professional or personal financial relationships that produce healthcare goods or services. So let's talk just a little bit about, I already mentioned that we're going to be doing a review of medical articles that have been published. And we are really just starting to see things coming more consistently in the area of the auditory system. There are people that are reporting hearing loss and tinnitus as a complication of COVID-19. And of course, we have to keep in mind that the majority of medications that are used to treat COVID-19 at this point in time are already known to be ototoxic at certain dosing levels. So something that we have to keep in mind as we work through this course. And I would like for you to think about, as we talk through some of these things, what are some of the clinical implications, some things that we really need to look at, including in our day-to-day interactions with patients, as far as asking if they've had COVID and digging into that from a case history standpoint. And that we're going to talk about as we move along. So after this course, you should be able to identify current long-term complications that have been linked to the coronavirus, at least the ones that we know at this point in time. Recognize emerging information related to COVID-19 and hearing loss. And then we're going to, as I mentioned, do just a brief description of medications that have been used for treatment. So what is COVID-19? I know what it is that we have been hearing it for months, but as we look at a formal definition of COVID-19, it is a mild to severe respiratory illness that is caused by a coronavirus, which is the severe acute respiratory syndrome coronavirus 2 of the genus beta coronavirus 1. So it's transmitted chiefly by contact with infectious material such as respiratory droplets. I think that this has been an area of the transmission area that has continued to show itself is the respiratory droplets that can be in the air as well as on surfaces. Thus the reason that we are wearing masks as a deterrent to that. And there have been a number of initial symptoms that have been discussed in COVID, that being a fever, cough, shortness of breath, leading into a progression of pneumonia, and then respiratory failure in many cases. And we have become very familiar with what the coronavirus cell looks like. So I, of course, did not want us to forget what we are talking about in the COVID-19 arena. So we have found in an emerging manifestations of COVID-19 has started to show a lot of systemic issues that they're finding across a multitude of organs and systems. And early research has been showing that the disease literally attacks multiple organs and systems, and how it is doing that and which systems it may impact each individual vary tremendously. As we know in what we've been hearing and reading, that no two patients may follow down the same path of manifestations that they have as COVID-19 actually continues and advances. A lot of it has been linked to inflammatory process within the organs, which has likely related to a significant cellular level damage. And we're going to talk just a little bit about that as we talk about hearing. And there is ongoing research currently, and there's going to be, I would suspect, ongoing research for a number of years as we are discovering what the impact of COVID-19 has been to our world population. A lot of those studies are also being done post-mortem, where families are giving permission for their loved ones that they've lost to COVID to at least be able to commit and contribute to additional information that may help others in the future. So we have a lot yet to learn from, I'm certain, post-mortem studies as well. So we talk about acute phases and then, of course, chronic or long-term issues with almost any type of illness. The acute reported symptoms initially with COVID, and again, these are very variable based off individual, but the general ones would be fever, fatigue, cough, headache, loss of taste and smell. And as we know, there are other things that have come into play in that as well, one of which we're going to talk about as being hearing and tinnitus and vestibular problems today. And then when we get into the long-term areas, I truly believe, after reviewing the literature that's in this area, that we are still going to continue to see long-term effects, or what they are now starting to call in the research long timers, where they are actually having a lot of ongoing symptoms even after the disease and the virus is no longer detectable in their system. So long-term fatigue, headaches, vertigo, difficulty with cognition. A lot of people reporting that as far as almost like a foggy brain syndrome. Hair loss, cardiac issues, numbness, redness in the toes, diminished respiratory fitness, just to mention the top number of those. So as we start to look through a few of the studies, I tried to select studies that were representative not only of different areas of the country, but also different ways of which this information came about. So in our first study, it's a retrospective study that was conducted across 4 Chinese hospitals. And they looked at the patients retrospectively that had required ENT consults. And there were 20 of those hospitalized patients that ENT consults were requested, the average age being about 63 years old. And they did find that of those 20 hospitalized patients, that 25% of those actually presented at ENT consult with tinnitus and dizziness. So this is where, when they started going backwards, of course, as you can imagine, in China, where we know of the first occurrences of the coronavirus, I'm sure that they were in a state of scramble as they were starting to see more and more people coming in and presenting with these issues. So a retrospective study to look back in those early first days in China, I thought was an important thing to look at, that even back to those points in time, when you look back retrospectively, there were beginning signs of ENT related issues from COVID. The second study is looking at a study that was done, which was one of my favorite studies that I looked at. It was done in Egypt, and they had matched groups that they actually put together. 20 of those were symptomless yet positive COVID cases, and they matched them to a control group that were in the same age, obviously, with negative COVID testing. And all of these individuals in both groups, both the COVID positive as well as the COVID negative group, had previously reported normal hearing. They were age range of 20 to 50 years old. They did full audiological batteries on these patients, all of them, including otoacoustic emissions. And what they found was that in the symptomless positive group, so these individuals might never have been known to have COVID-19 because they did not have any particular symptoms. They found that the high frequency thresholds, as well as the transient evoked potentials, otoacoustic emissions, amplitudes were significantly worse in the group that had COVID. And that would, again, talking back where we mentioned that the damage at cellular level, when you think of the fact that the otoacoustic emission is looking at the outer hair cells, and those can very easily be assessed with otoacoustic emissions. I think it speaks to the need of making sure that we do full batteries on individuals that have had COVID, even though they have not necessarily reported difficulty in hearing. So I think that this is something to keep in the back of our mind, that symptomless individuals are showing damage to the auditory system, even though they may not be reporting that they have difficulty hearing. The third study was around sudden sensorineural hearing loss. And if you think about the way that we experience patients in the sudden sensorineural hearing loss arena, it would just make sense that this virus would very possibly fall into that arena of creating the opportunity for a sudden loss of hearing if they have contracted the virus. So in this particular study, this came out of Turkey. There were 5 male patients with a mean age of 40, essentially 41 years of age. What's interesting about this particular study is when they reported to the outpatient clinic, their sole complaint was hearing loss. So they had reported, only with a symptom of hearing loss. And so at that time, because of the instance of COVID, of course, they were doing COVID testing. So only 1 of the 5 patients actually tested positive for COVID. And in this particular case, they did report complete recovery of hearing on the 11th day of treatment. And that treatment that was being used in Turkey was actually set up and designed by the health ministry of that country. And they were giving oral hydroxychloroquine, 200 milligrams twice a day for 5 days. So on the 11th day in this particular individual who had tested positive for COVID, he did actually have a recovery of hearing on the 11th day of treatment. The fourth study that we are going to look at is a study out of Iran, and it is focusing primarily on symptom reports of vertigo and hearing loss. So researchers were finding that they kept encountering multiple patients that were presenting with hearing loss and dizziness with a COVID diagnosis. So they started to look backwards at 6 patients, and they were aged 22 to 40 years old. And as they looked at those individuals who had the presentation of hearing loss and dizziness, along with a positive COVID diagnosis, they noted their findings, again, being mild symptoms of cough, fever, and breathing difficulties, but no prior history of hearing or balance symptoms prior to contracting COVID. And of those 6 patients, 4 of those patients had tinnitus, 2 of the patients had vertigo, and all of the patients showed a unilateral mild moderate hearing loss in at least 1 ear. And so again, if you think about the impact to the auditory system, it being unilateral, it being virally induced, and in this case, did follow that unilateral pattern across all individuals that were identified. And in this particular study, this is just a one individual single case study. And I really wanted to spend just a little bit of time on this one, simply because it speaks to his journey through the COVID-19 process. So he was a 60-year-old male that was admitted to the ICU with confirmed COVID, and he was admitted 8 days post-onset. And when he was discharged from the ICU, he was in ICU for quite a number of days. When he was discharged from the ICU, they moved him off the floor, and he was experiencing what they described as hyperactive delirium. So he was not cognizant of his surroundings. He was delirious, not speaking in a fashion that made sense to individuals and things of that sort. Once they got him stable and his mental state recovered, he was reporting deafness and loud tinnitus, even though he had no prior history pre-COVID. So they performed evoked potentials, and they confirmed the hearing loss and referred for additional audiological workup, which they did find resulted in a complete loss of hearing that was sensorineural in nature in the right ear. He was given zithromycin as well as furosemide, and they continued on looking at the outcome of the impact of COVID to him. They performed an MRI, and it had pronounced contrast enhancement in the cochlea of the right ear, with a partial decrease in fluid signal at the basal turn of the cochlea. They found the meningeal contrast enhancement was seen at the base of the temporal lobe, and all of these were interpreted as signs of the inflammatory process in the cochlea, which can, of course, lead to soft tissue deformation, ossification of the cochlea. So in this particular case, they were concerned in what they were seeing in the MRI that if they did not perform cochlear implant surgery quickly, that they might not be able to in the future if he continued on with the ossification. That they were concerned about not being able to implant the electrodes properly. So they did go ahead and implant him. And what they found after he was implanted is that he did very, very well. Obviously, we know with cochlear implants that if we are implanted quickly, after our loss of hearing, that there is a much more rapid reboot to the hearing system than for, as an example, an individual who has had longstanding hearing loss over a number of years. So in this particular case, I thought that was very, very interesting how quickly they moved him into cochlear implant surgery because of the concern of the actual issues that were going on in the cochlea that they could see in the MRI. So they proceeded rather quickly. So I thought that was also a very interesting study. What also has been looked at recently as well, as I mentioned in the introduction, where we were talking about the postmortem studies, these individuals that they are finding that they are doing, that they are rushing the ability to be able to do some of these postmortem studies and look at COVID-19, they actually have found genetic material that is specific to COVID-19 in the middle ear and mastoid mucosa of a number of patients. And this is, again, demonstrating and confirming the first possible causal link pathway that can lead to hearing imbalance disorders. Because of course, if we have the virus active in the middle ear mucosa and the middle ear space, that is obviously going to run the risk of being able to get into the inner ear through the round and or oval windows of the cochlea. And I said that we would talk just briefly about the current treatment of COVID-19. And of course, as you know, there's been a lot of different types of medications, I'm sure, that have been tried along the way. But what we have found in the literature is that almost every medication that would be used to treat COVID-19 is ototoxic in nature. And I think that's very important to talk about, especially when we know that we have had incidences already of people reporting with hearing loss as their symptom. We talked about that in a couple of the studies. So there have been indications of that being maybe even the sole presentation in COVID-19, and yet the treatments that we are familiar with are also ototoxic in nature, depending again on dose and length of time, and of course those sort of things as far as the ototoxicity. One thing that I think is extremely important to focus on is that ototoxicity has not only shown itself to contribute to sensorineural hearing loss, but also tinnitus issues and balance issues that actually can have a very strong potential impact to quality of life because at the point of onset of hearing loss and things of that sort, we can continue to run into depression and self-isolation because of loss of hearing. And then, of course, the chloroquine and hydrochloroquine, who have been widely promoted and used in the pandemic, has shown data that suggests that in many treated cases, side effects such as sensorineural hearing loss, tinnitus, and other types of persistent imbalance problems were common. So unfortunately, not only can the disease itself cause hearing loss that may be irreversible. Also, the drugs that we are using to combat this problem, depending on the length of time that they have to be used, and again, that being dictated by the severity of the individual's symptoms and illness as they progress through COVID-19, could require them to be on medication for quite a number of days or even weeks when we know that it is ototoxic in nature. We talked about the impact of ototoxicity and drug treatment being related to the dose and duration. And of course, the other thing that we have to keep in mind is that there are also other patient-related factors that come into play, other concomitant diseases and other medications that they may have to take for other illnesses that they have, that they take medication on a consistent basis, that when they now add in some of the other drugs that have been found to be effective in COVID, you can actually now have interactions between those drugs that could create issues for weeks or months as long as they have to be on that medication. So again, I think we're going to see some clinical takeaways from this. We know already that ototoxicity actually creates hair cell damage. That's why otoacoustic emissions are so widely used in the monitoring of ototoxic medications, because it's been proven that we can see changes at the cellular level or the outer hair cell level long before we can see actual threshold changes. So again, when we talk about understanding what's happening in that sensory organ, otoacoustic emissions brings a lot to the table to give us a sneak peek into possibly things that are occurring that we might have missed if we were not using otoacoustic emissions. And then again, of course, we mentioned the synergistic effects. There is, of course, with any medication mixtures that we have to take as patients that may have multiple comorbidities, we always have to take a look at what other medications are also being administered in those individuals. And I think that we really don't have all the information yet on this. Of course, and it's just going to cause just more time and research to occur for us to follow what these medications are doing and what some of their synergistic effects could be. And there's been a lot of talk about teleaudiology, of course, in COVID. And one thing I wanted to kind of bring up at this point is part of the challenge in the COVID environment, of course, has been related to the patient as well as related to the provider staff and things of that sort, because we do really need to be monitoring changes in hearing that could be occurring, especially in light of what we've just reviewed that is occurring in the literature. We really do need to be monitoring these individuals. So we have to think about how can we do that in a fashion that the patients feel safe, that they, again, we know that people that have had COVID-19, many of them are exhibiting post-traumatic syndrome from just the fact that many of them have survived COVID, but yet they're left with lingering anxiety about socializing and things of that sort. So teleaudiology does bring an opportunity to be able to monitor well, keep social distancing, of course. But the other consideration on that is that we don't really have the ability at that point to have in a teleaudiology format, especially if the patient is homebound or in a facility where they are not able to have in-person providers come in. We don't tend to have ideal testing environments there. So we have to keep, there's that balance as well. So could teleaudiology be an answer in being able to monitor changes better, especially in the case of needing to be socially distanced? I do believe that is true. However, it is not widely developed to this date to be able to do all the testing in a teleaudiology format that we would want. As an example, otoacoustic emissions, and some of the other tests that we know are very sensitive in this area, but are not really being performed at this point in time in the teleaudiology arena. And of course, we have noted, and I think that as we come toward the end of our discussion of this COVID-19 review, is that we have seen in the literature that the virus can potentially target the inner ear directly. And so we have to be aware of this as we are constantly seeing patients. So where are some of our clinical indications? I think audiologists and physicians alike have to take precautions, of course, in dealing with patients, that we know we deal with day in and day out, with precautions of masks and face shields and things of that sort. However, with attention to middle ear drainage especially, because as we noted in the postmortem studies, they have found COVID-19 genetic material inside the middle ear mucosa, which would have an impact during any kind of middle ear surgery that would need to be done, where that virus could aerosol into the air during surgery, as well as just drainage from the ear that might be occurring that would have COVID-19 viral materials within it that we could actually put ourselves at risk if not using the right kind of precautions. Of course, the other thing is that one thing that we did in our practice fairly early on in COVID is we started to include questions in our case history about not just the possible exposure to COVID, but now also looking at did they have COVID themselves, whether they were symptomatic or not. All these individuals should be referred for audiological workup. And then based off of the research that we've talked about today, we really need to be monitoring these people because we don't know yet what the progressive components might be in light of some of this long-standing lingering symptoms. And then again, ultra high frequency thresholds as well as otoacoustic emissions may be those places that we see those changes first, and we need to be aware of that. There are 2 pages of references here for you, and I encourage you to continue to do your own research in that area, and I thank you for your attention.